May I invite our next speaker. We'll have the questions, of course, in the discussion session. So if you can hold your questions, please. So I would like to invite the next speaker, Dr. Manish Bansal, is going to talk about role of echocardiography in cardiac emergency.
First of all, a very good morning to the respected chairpersons and all the delegates. I would like to thank Dr. H.K. Chopra and the organizers for having given me opportunity to speak in this important meeting. In the ER, there are two main objectives of diagnostic workup whenever we come across a patient. First is that we should be able to make the diagnosis very promptly. And second, which is probably more important, is that we should not be missing any important disease, any serious illness should not be missed. So we require a modality which has the capability to provide a large amount of information very quickly, and the modality should be easily accessible. Now, echo has several attributes which make it ideally suited for use in the emergency room. Like, it provides huge amount of information in just a matter of few minutes. It is completely non-invasive, easily available, portable, so that it can be moved to any part in the hospital, and it virtually does not cause any harm. There is no radiation exposure, no contrast risk, and no injuries involved associated with echo. Now, in the emergency room, we come across a number of clinical dilemmas. Most important are chest pain, breathing difficulty, various types of arrhythmias, hypotension, and patients can present with unexplained fever, stroke, and of course trauma. Of these, chest pain undoubtedly is the most important clinical condition, not only because it is the most important, but also because it has got very varied implications in terms of patient outcome and medico-legal issues also. Now, chest pain alone is responsible for almost 5 million ED visits every year in the US. But importantly, only 1/3 of these visits are because of a cardiac cause. However, a more serious and more important fact is that nearly 2% of MI patients are actually missed in the ER and erroneously discharged. Now, this is something which is really disastrous, because as we know, in MI, the most important thing to achieve good outcome is to have early accurate diagnosis and to be able to institute treatment as promptly as possible. So if a diagnosis is missed, it can lead to fatal complications, and it is also therefore the biggest reason for malpractice litigation in the US against the ED doctors. Now, chest pain is not cardiac always, as I mentioned. It can be because of pulmonary embolism, it can be aortic dissection, it can be because of respiratory illnesses like pneumothorax, or many times it's because of GI disorders like gastritis or cholelithiasis. But the most important question before us whenever a chest pain patient comes is whether it is cardiac or not and whether it is life threatening. Unfortunately, we have only one modality to reach this diagnosis in the ER, one easily available modality, and that is ECG. But ECG itself has several limitations. In almost half of the patients with non-ST elevation MI or unstable angina, ECG is non-diagnostic. It has good diagnostic accuracy for ST elevation MI, but for others, diagnostic accuracy is actually only modest. And almost 3/4 of all patients with non-Q MI present with ST depression only, which may often go unnoticed also or unrecognized. And 80% of these patients have been shown to have subtotal coronary occlusion, which can very easily result in more serious complications like ST elevation MI. Now, in such a setting, if we have echo which can show us regional wall motion abnormalities, even if they are old, it indicates very high possibility of this chest pain being cardiac in origin, and it will alert the treating physician to the possibility of CAD, so that the patient is not at least discharged. Then you send cardiac enzymes, which will take few hours to confirm the diagnosis, and then you can do other tests also to find out whether this particular presentation is because of coronary event or not, but at least you are not going to miss MI or a serious cardiac illness. But as I said, not all chest pain patients are because of CAD. There are many other causes also which need to be diagnosed well in time. Like this example here, a 62-year-old lady presented with 12-hour duration of crushing chest pain, which was maximum at the onset. She just had sinus tachycardia, ECG was non-diagnostic, and she was treated as acute coronary syndrome, was started on heparin, aspirin and NTG. And cardiac enzymes were sent. So she was being treated as ACS until echo was done, and which showed a dissection flap in the ascending aorta with significant AR. Same images in short axis view and 3D. So see, these echo pictures immediately changed the diagnosis, and now we realized that the treatment that she was receiving was actually contraindicated. The heparin was stopped immediately, aspirin was stopped, and she was rushed to the ER, to the OT for immediate surgery. Another common presentation in ER is breathing difficulty. Now again, in breathing difficulty, the most important question is whether it is LVF or COAD. And then there are other causes also, like patient can have severe mitral stenosis, mitral regurgitation, pulmonary embolism, and likewise. Now in this example, a 60-year-old gentleman, chronic smoker, known case of COAD, presented with acute shortness of breath. Clinical examination revealed bilateral bronchi. Blood pressure was normal. So what is the diagnosis? Whether it is COAD with acute exacerbation or it is acute LVF. Now clinically it is not possible to make this differentiation. But if echo shows large amount of wall motion abnormalities or significant LV systolic dysfunction or severe MR like this, then we know that it's most likely LVF and should be treated according to that, not just be given bronchodilators, nebulizations and oxygen. Another patient, 34-year-old gentleman, had road traffic accident. 1 week later presented with sudden shortness of breath. Clinical examination was unremarkable, but echo showed large amount of thrombi in both pulmonary arteries. So we knew that this patient had pulmonary embolism, and since this was very short duration, could be thrombolized or taken up for surgery, whatever, could be managed appropriately. Another lady, 32-year-old patient, almost asymptomatic except for mild dyspnea, but one day she developed palpitations and presented with acute shortness of breath. Echo again was there for our rescue, showed severe mitral stenosis with significant turbulence across mitral valve and markedly elevated gradients with estimated valve area of 0.6 centimeter square. Now this is the diagnosis. Obviously clinically also we can make this diagnosis, but the kind of information that echo provides clinical examination alone cannot match that kind of information. Then patients can come with caudal rupture resulting in severe MR. That can also lead to sudden shortness of breath. Then another common reason for presentation to ER is stroke. Now whenever a patient with stroke comes, we have to first find out whether it's ischemic or hemorrhagic, and if it is ischemic, whether it is thrombotic or cardioembolic. Now this distinction, whether it is thrombotic or cardioembolic, is important because the management of these two conditions is different. Again, echo is of immense help here. It can show us LV apical clot or large LA clot, or it can show us clots in LA appendage. Sometimes they are patent foramen ovale with paradoxical embolism. And rarely we can have mobile atheroma in the ascending aorta, which can get dislodged and cause acute stroke. Another common indication is hypotension, which can be because of hypovolemia, it can be because of sepsis, or it can be because of some cardiac cause. Now, echo allows us to quickly have an assessment of fluid status. We can calculate central venous pressure, we can calculate LV filling pressure, we can estimate cardiac output, and we can, utilizing this information, quickly categorize patients into one of the three main groups of hypotension and shock, and treat the patient accordingly, because management of all these three conditions is totally different. And in addition to allowing us hemodynamic categorization, echo also can give us etiological diagnosis. Like in this patient, there was pericardial effusion resulting in tamponade. A patient here had interseptal MI 2 days ago, then had large defect in the interventricular septum with large left to right shunt and shock. Another patient, I'm sorry with the problem with the clips, but this patient had large pseudoaneurysm involving LV apex following MI, and again had shock. Some problem. I'm sorry, it's just not working. Patients can also come with unexplained fever, and they've had a number of investigations already done, blood cultures drawn, TLC, DLC, urine examination, and no cause is identifiable. In many such patients, the cause of fever is actually cardiac, and echo again is the modality which can give us the diagnosis. Like I was going to show a patient who was on hemodialysis and had a permanent catheter put into the jugular, into the subclavian vein, and the patient had a vegetation on the tip of the catheter, which was the cause of fever. So once that was diagnosed, he was put on appropriate and empirical antibiotic therapy for 6 weeks, and the catheter was removed after some time. Patient improved completely. So just coming to the last slide, these were some of the illustrative examples of showing how echo can be helpful in the emergency room. As I mentioned at the beginning, there are two main attributes of echo. One is that it can provide large amount of information in one go, and second, it is highly portable, can be moved to any place in the hospital very easily. And now the echo is becoming more and more portable. We have handheld devices, and very soon we'll have a device something like this, which is threatening to replace even a stethoscope. Thank you.